A pleasant day to everyone. It is a pleasure to deliver this talk for the Korean Heart Rhythm Society 2021 scientific sessions. And I would like to thank the organizers for the invitation. And as we continue to navigate the raging COVID-19 pandemic, we are fortunate to be able to share science through this virtual platform. And I bring you greetings from my beautiful country, the Philippines. These are my disclosures. The turn of the 21st century saw a rapidly growing and aging population with a vast improvement in healthcare and advancements in the medical treatment and intervention of chronic diseases. With this, we also saw a growing epidemic of atrial fibrillation, which continued to pose a significant health impact. A wealth of scientific evidence have paved the way for treatment guidelines, which recommend chronic anticoagulation for atrial fibrillation patients who have a high stroke risk. And this is based on the CHADS-VAS score. This thromboembolic prophylaxis is recommended regardless of the type of atrial fibrillation, whether paroxysmal, persistent, or permanent, and whether the patient is asymptomatic or symptomatic. And in the last 12 years, non-vitamin K oral anticoagulants, or your NOACs, have revolutionized stroke prevention with their advantageous pharmacologic profile compared to warfarin, a rapid onset of action, fast offset, less issues with bleeding, and less interactions. We also saw the rapid and tremendous progress in terms of medical and cardiovascular technology in this century. The advent of mobile electronic health applications and the entry of the era of digital healthcare have also revolutionized the way we take care of and manage our cardiovascular patients. Recently, these digital technology have engaged our patients to the benefits of mobile health in modifying their health behavior and improving overall health. One technology that has seen fast-paced advancements is in the area of cardiac implantable devices, and that includes pacemakers and defibrillators, as well as monitoring devices for arrhythmia. These have allowed for an improved monitoring and detection of certain rhythm disorders, such as atrial fibrillation. But more recently, the development of smartphones with capabilities to record ECG tracings have seen a huge potential in terms of screening and detection, as well as monitoring of atrial fibrillation. So what do we know about atrial fibrillation today? This is a growing problem in our aging patient population. It has substantial morbidity with symptoms of palpitations and heart failure, and a substantial risk for thromboembolic stroke and mortality. Now, the thing is, AF patients with symptoms have a higher probability of earlier diagnosis and receiving evaluation about relevant medical treatment compared to asymptomatic patients. But the vast majority of AF episodes are actually asymptomatic, and these patients are also at risk for stroke. Now, guidelines recommend, however, that asymptomatic documented AF should be treated the same as symptomatic AF with regard to oral anticoagulation. And conventionally, the guidelines also mandate that same anticoagulation strategy, whether the patient has paroxysmal, persistent, or permanent atrial fibrillation. Now, however, recent data have alluded to the AF burden in relation to thromboembolic risk. Unfortunately, the thromboembolic risk related to different durations of AF episodes is incompletely understood. But we now seem to have to be seeing more data that may seem to suggest that short episodes of paroxysmal atrial fibrillation patients in selected patients may not carry the same risk for stroke compared to longer episodes. And the advent of devices, both implanted and handheld, have allowed for a more intensive and improved monitoring for episodes of AF, giving a high yield in the detection of this arrhythmia with capabilities of catching asymptomatic episodes more. Now, these devices have changed the landscape of atrial fibrillation detection. Pacemakers and ICDs with an atrial lead have allowed detection and diagnosis of supraventricular tachyarrhythmias recorded as atrial high rate episodes. Other devices, such as your ILR or your implantable loop recorder, and event monitors, as well as handheld ECGs, allow an improved yield in atrial fibrillation and arrhythmia detection. Recently, smartphone ECGs, as well as the Apple Watch with ECG capabilities, have brought us to sort of the next level of mobile digital cardiac electrophysiologic care of our patients. But let's start with the proper terminology to put things in proper perspectives. Asymptomatic atrial fibrillation is defined as AF that is diagnosed by ECG but with no symptoms. And these are usually diagnosed incidentally. Silent AF is basically synonymous with asymptomatic atrial fibrillation. But more specifically, this refers to asymptomatic AF often presenting with complications such as a stroke. Now, your atrial high rate episodes, or your AHRE, are atrial tachycardia rates that are more than 190 beats per minute, recorded by the atrial electrode of a pacemaker or ICD. Subclinical atrial fibrillation refers to atrial fibrillation episodes not correlated with symptoms, while clinical AF is any AF, whether symptomatic or asymptomatic, that is diagnosed by an ECG. Now, studies using implantable devices and event recorders have shown an improved detection of these subclinical AF, whether as atrial high rate episodes or as ECG detected arrhythmias. And they have shown a correlation with the development of clinical AF and with the risk for stroke. Now, it is understandable that more prolonged monitoring, which is provided by these gadgets, allow an improved yield in the diagnosis of AF, of which a huge subset are intermittent and have no symptoms. The MOST and the ASSERT studies, which involve pacemakers, the EMBRACE trial, which uses event recorders, and the CRYSTAL AF trial and REVEAL AF studies using implantable loop recorders, have shown improved AF detection and the association of these subclinical AF with stroke and mortality. Now, a lot of data has also emerged for smartphone ECGs in improving detection of AF. The Cardia, a live core device, which allows ECG recording on a smartphone, has been shown to increase the detection of atrial fibrillation with acceptable sensitivity and specificity. And this opened up opportunities and potential for its use as a screening tool. Several studies involving high-risk patients yielded better detection of atrial fibrillation and potential use in triggering treatment with an anticoagulant. Now, if we look into the landmark studies dealing with your AHREs, or your atrial high rate episodes, in patients with devices such as pacemakers and ICDs, we have here the data from the MOST trials, the TRANS, and the ASSERT. And you can see the different cutoffs for atrial fibrillation burdens ranging from 5 minutes to 5 hours. And it appears to be consistent that AHREs, or atrial high rate episodes, are associated with thromboembolic risk, with patients with high AF burden correlating with a higher risk of ischemic stroke compared to low burden. Now, atrial high rate episodes also have been shown to eventually predict the development of a future clinical atrial fibrillation, while atrial high rate episodes of more than 5 minutes are associated with a higher risk for stroke and systemic embolism, with longer episodes connoting a greater risk. Now, while earlier trial and observational data seem to show relatively the same stroke risk for both paroxysmal and non-paroxysmal AF, recent trial data seem to consistently show lower residual thromboembolic risk for anticoagulated patients with paroxysmal compared to persistent AF. And among the non-anticoagulated patients, stroke risk was also shown to be lower with paroxysmal compared to persistent. These graphs are part of a systematic review evaluating the impact of atrial fibrillation type on thromboembolism, bleeding, and mortality. And this included your Aristotle trial, your Rocket AF, the Averroes trial, Rely, and Engage data. And you can see that overall, comparing your paroxysmal and non-paroxysmal atrial fibrillation, the risk for stroke and systemic embolism was higher in non-paroxysmal AF in both patients who were anticoagulated and non-anticoagulated. So with all these in mind, we create a what-if scenario wherein if we are able to continuously monitor the occurrence of atrial fibrillation episodes with the use of devices, especially for patients who have paroxysmal episodes, and at that time initiate anticoagulation in an as-needed basis so that chronic anticoagulation with its inherent risks of bleeding may be avoided, but we maintain the same protection against stroke. Such is the concept behind tailored anticoagulation strategy, or the pill-in-the-pocket anticoagulation. Let's first define what this tailored or pill-in-the-pocket anticoagulation is. It is a strategy of continuously monitoring for atrial fibrillation with the use of an implanted device, such as an pacemaker or an ICD, or implantable loop recorder, or wearable technology such as a smartphone, a watch, or a handheld ECG. Then initiating oral anticoagulation for a limited time to address the thromboembolic risk. Now, to be strict about it, this is a strategy for patients with intermittent episodes of atrial fibrillation. The rationale behind this is the intention to prevent stroke related to the onset of atrial fibrillation, hence minimally exposing the patient to the risk of bleeding from chronic anticoagulants. And it is applicable especially for the NOACs, which have a more rapid onset and offset of action and is more feasible for an on-demand strategy. To demonstrate the mechanism of the strategy, it applies to the patient with paroxysmal atrial fibrillation with either an implanted electronic device or a gadget such as a smartphone or watch capable of recording ECG. At the onset of atrial fibrillation, whether the symptoms prompting recording with the gadget or as directed or as detected and monitored regularly with the device as an atrial high rate episodes, a NOAC is initiated and continued for a period of time, and patient continuously monitors the progress of the arrhythmia. Now, the recording of no atrial fibrillation for a specified time, or the termination of the atrial fibrillation and documentation of AF-free episode for a period of time, the NOAC is discontinued, and continuous monitoring for atrial fibrillation episodes is done, and the algorithm is applied accordingly. There are, however, important caveats and controversies related to this concept. The temporal relationship between atrial fibrillation episodes and the occurrence of stroke is somehow not definite, and atrial fibrillation episodes do not regularly correlate temporally with the stroke event. Furthermore, the length of the AF episodes that correlated with stroke risk varies across studies from 5 minutes to 24 hours. And the duration of AF that is associated with stroke is likely not constant in all patients. At this point, it is still incompletely understood whether the AF duration, the burden or density is a better measure of the stroke risk. Also, how long the risk for stroke after an atrial fibrillation event lasts thereafter is also a big question mark. And we still don't have the clear guidelines on how to treat these patients in terms of thromboembolic prophylaxis. One important caveat is the temporal relationship of atrial fibrillation to stroke events. In the analysis of the trends and assert data among majority of patients who developed a stroke, you can see that there was no atrial high rate episodes or no AF episodes that occurred in the period during the stroke. In fact, 73 to 94%, as seen here, had no AF in the recent 30 days prior to the stroke, with only about 13 to 16% having AF detected only after the stroke event. The occurrence of atrial high rate episodes and stroke do not always correlate temporally. Some patients may have stroke other than cardioembolic stroke, and the association between the AHRE and stroke may not be directly causal. Atrial high rate episodes may be actually a marker of inflammation, a prothrombotic state, or underlying atrial myopathy. Now, most patients with atrial high rate episodes who get a stroke are actually not experiencing the AHRE at the time of the diagnosis. And the period following the AHRE and the overall presence of AHRE is associated with significant risk and stroke. In the assert, in fact, only one patient had an AHRE at the time of the stroke. And in the 14 patients who had an AHRE, the median interval from the AHRE to the stroke or systemic embolism event was actually 339 days. And similarly with the trend study, among the 20 patients with stroke who had an atrial fibrillation before the event, about 14 were not in AF during the stroke, with the last AHRE actually occurring 168 days average before the stroke. So what do the guidelines say? Well, this is an area where there are no recommendations or consensus yet. However, guidance states that the need for and the choice of anticoagulant therapy should be evaluated at regular intervals. Nothing specific beyond that. What do the data show? Unfortunately, only small studies. Not enough for a recommendation, but I guess worth looking at. This concept was sort of explored in small studies using the insertable cardiac monitor. It was shown to be useful in 65 patients after atrial fibrillation ablation who remained free from AF 3 months after the procedure. Post-ablation, the monitor was inserted and the anticoagulation discontinued. Daily monitoring done to detect atrial fibrillation of more than 1 hour duration. And after a follow-up period of 32 months, 63% of the patients with AF burden less than 1 hour per day stayed off the anticoagulant, and no stroke, transient ischemic attack, or other embolic events were noted. Now, a related study by Mascarenhas et al. Looked at 70 patients with paroxysmal AF, but with sinus rhythm and on antiarrhythmic drug treatment. They had substantial stroke risk and bleeding risk, and anticoagulation was discontinued if the patient stayed in sinus rhythm or had low atrial fibrillation burden of less than 1% for more than 3 months. And after a follow-up of 23 months, 76% of patients who remained on sinus rhythm or less than 1% AF burden for 3 months stopped the anticoagulant, and this was associated with no adverse events. Now, tailored anticoagulation was also previously investigated in a population of patients with dual chamber ICDs and biventricular ICDs. And this was the IMPACT trial, a randomized controlled trial comparing outcomes in tailored anticoagulation and continuous anticoagulation. And in this study, different criteria based on the CHADS-2 score existed to start or stop the anticoagulation. And it included 2,700 patients with heart failure, with majority on warfarin, and dual chamber ICD or a CRTD, randomized to 2 arms, chronic anticoagulation versus a start and stop oral anticoagulant based on remote monitoring. Now, unfortunately, the study was terminated early due to lack of benefit in the tailored anticoagulation arm. But at the time the study was performed, however, NOACs were not widely available, and warfarin was the primary mode of anticoagulation. The lack of positive outcome in the study was likely related to the inclusion of a higher risk population, as well as a greater number of days required for the warfarin to reach therapeutic levels. In addition, patients did not have to have AF to be enrolled. Thus, it diluted the study population, which was reflected in a very low incidence in thromboembolic events, the number of 69, prior to the study termination. Now, the feasibility of tailored anticoagulation was also verified in the REACT.com trial, a pilot study which used the Medtronic Reveal XT implantable loop recorder to assess atrial fibrillation burden in 59 patients with a CHADS-2 score of 1 to 2 and infrequent AF episodes on a NOAC. The REACT.com study protocol entailed patients would stop the NOAC if they remained free of continuous episodes of atrial tachycardia or atrial fibrillation lasting for more than 1 hour for 30 continuous days. And they resumed the NOAC if they experience a continuous atrial tachycardia or atrial fibrillation episode lasting more than 1 hour. Now, the study population consisted of younger patients with the average age of 67 years old and did not need to have a pacemaker or an ICD. The study demonstrated a 94% reduction in the time on anticoagulation with few adverse events, no strokes, and 1 TIA in a patient with a CHADS-2 score of 1 who was off anticoagulation and was on aspirin. Now, the TACTIC AF trial was a pilot study evaluating the novel strategy of tailored anticoagulation using NOACs in a patients with a St. Jude medical pacemaker or ICD and with an endocardial atrial lead for atrial fibrillation or atrial tachycardia detection, along with wireless remote monitoring capabilities to detect AF. In this trial, 48 patients with non-permanent AF on an NOAC with a CHADS-2 score of 1 to 3 and no previous stroke were included. And the group was randomized to either standard chronic NOAC versus a pill-in-the-pocket anticoagulation strategy. Now, in the TACTIC AF study, monitoring for your atrial tachycardia or atrial fibrillation was done via scheduled and device-triggered transmission, as well as patient-alerted transmissions. Anticoagulation was stopped if there were no AF episodes of more than 6 minutes and AF burden was less than 6 hours per day for 30 continuous days. NOAC was reinitiated for 30 days if AF recurred or continued if the AF persisted. Now, in this trial, the control arm was actually removed after 2 years to facilitate enrollment, and the trial continued on as a single arm. The study actually demonstrated the feasibility of tailored NOAC administration in order to reduce the anticoagulation utilization. Your tailored anticoagulant resulted in the 75% reduction in the time on anticoagulation compared to standard of care, with continuous anticoagulation regardless of AF burden, with few adverse events and no thromboembolic events. Although this pilot study was small and underpowered to detect thromboembolic events, the results were nonetheless encouraging, and it demonstrated further that the further studies of tailored anticoagulation is actually warranted. All these studies showed the ability to monitor patients remotely and treat with a rapid action NOAC, allowing for a pill-in-the-pocket strategy. And they showed that the strategy is feasible. However, it is not definite if it is safe in providing stroke prevention compared to the recommended chronic anticoagulation. Therefore, further studies are warranted in this aspect. There is a future study embarking on the use of the Apple Watch Series 4, which has ECG recording capabilities. And this is the REACT AF trial. It plans to include 5,000 patients with paroxysmal atrial fibrillation, CHADS-VAS score of 1 to 4, randomized to chronic NOAC versus a pill-in-the-pocket anticoagulation strategy, using atrial fibrillation of more than 1 hour as the marker. And the trial will look at endpoints of stroke, systemic embolism, cardiovascular death, as well as bleeding after 3 years. The research to date is not yet at that point where we have definite answers for a pill-in-the-pocket strategy. However, there seem to be positive points for this scheme. First, it allows for a more patient-centered, patient-directed approach in anticoagulation in response to an atrial fibrillation or an atrial high rate episode. Patients will be active participants in their own care by taking responsibility of wearing the watch, if it's the watch that is used, looking at the data, and responding. and this can have trickle-down effects on other preventive health behaviors. We have seen similar strategies with hypertension and diabetes, where self-monitoring of the blood pressure and glucose allows patients to be more engaged in their care, responding with the necessary treatment. The comparison here is that hypertension and diabetes are high prevalence conditions, and where self-monitoring has a low immediate impact. Atrial fibrillation, on the other hand, has a lower prevalence, but self-monitoring and early treatment has a potentially high immediate impact. Let me share to you these perspectives for the tailored pill-in-the-pocket anticoagulation strategy. It is definitely not for everyone with atrial fibrillation. But the best candidates, if and when more data will come out to allow for its use, will be your paroxysmal atrial fibrillation patients who have a low CHA2DS2-VASc score. It will preferably be for younger and more active patients. It is not for older patients who have hypertension, heart failure, diabetes, and high CHA2DS2-VASc score, who eventually should be on long-term anticoagulants. Now, post-AF ablation patients on self-monitoring for recurrence of AF episodes after a successful ablation procedure might be fitting candidates, as well as those patients on a rhythm control strategy using or taking an antiarrhythmic drugs. Indeed, this is a treatment strategy that allows for an individualized treatment for atrial fibrillation patients. And these patients might potentially include one half of the atrial fibrillation population. So tailored anticoagulation strategy and its associated reduction in the time on anticoagulation has the potential to reduce hemorrhagic events associated with anticoagulation. It can reduce the cost and improve quality of life. Additionally, if future studies confirm the safety of tailored anticoagulation strategy, then successful rhythm control might allow some patients with atrial fibrillation appropriate risk factors and the ability for continuous remote monitoring with an implantable or a wearable device capable of continuous rhythm monitoring to safely stop or start oral anticoagulation during prolonged periods of sinus rhythm. We seem to be seeing emerging evidence showing that AF burden might be correlated to stroke risk, but there are still controversies on the temporal relationship of atrial fibrillation to the stroke event. Indeed, this is one area that will see more work and coming data in the years ahead. Thank you very much for your kind attention.